I have no idea what Dr. Gerda Maceo told about me. I wish I grew up learning Spanish, and I wish I could have given this talk in Spanish. My apologies. I have to do it in English. Thanks, Gerda, for whatever you said about me. Thanks for the kind invitation to speak at this meeting here. I just found out what a great meeting this is. And most importantly, thank you for all the kind hospitalities. So Gerda asked me to talk about new innovations in cancer treatment. I'll give you a general overview of how we manage cancer patients from a radiation oncology perspective, what some of the current treatment technologies are, and what may be some on the horizon. So there's a lot of data in the literature that show for many cancer types, if they're detected early and cancer has not spread, I think I'm okay. Okay. So they can shut it off. We can't have both at the same time. And cancer has not spread. Those patients have, on an average of 9 in 10 chances for surviving beyond 5 years. On the other hand, if cancer is detected early and cancer has not metastasized, then those patients have, on an average of 9 in 10 chances for surviving beyond 5 years. So what might it take to change this balance? So here are some data from NCI CR database that illustrates the observation that I made. In this plot you see 6 top cancers that are the major cancer killers in the United States. The lung, prostate, breast, colorectal, pancreas, and liver. In many countries, many of these cancers also top cancer killers. This plot is broken down by when these cancers were diagnosed. So the green represent the data for localized disease, and the red triangles represent the data for metastatic disease. The horizontal scale shows survival, 5-year survival from 0% to 100%. So as you can see, the green diamonds tend to cluster to the right, meaning they have a much higher 5-year survival. Prostate, breast, about 100% 5-year survival. But on the other hand, the red triangles tend to be on the left. These are the metastatic disease. And the main modality of treatment for this is systemic therapy. So even though, as you can see, remarkable advances have been made for localized disease, the outcome for metastatic disease is poor. These patients on the average live 1 in 10 beyond 5 years. So this is a major problem for metastatic disease. There has been significant advances that have been made in the last year in the world of systemic therapy. On the left, I have plotted here the survival. The upper curve is for patients who were treated with immunodrug, Pembro, and the lower curve is the survival for patients treated with chemotherapy. So you can see the staggering difference in the survival when patients are treated with immunodrug. This also shows survival with more recent advanced drugs. But again, you can see, as you extend this timeline from 27 months to about 36 months, this patient also start to, will eventually die. So that's the problem. So even the most advanced systemic therapy are still not working. Cancer is fundamentally escaping. So how do we improve on this promising foundation? One approach is to examine why cancer escaped from the promising drugs. And then if we can determine that, we can try to figure out how to address these escaping mechanisms. So I'll talk about this later. So from these two slides, one can make some observations and maybe ask some probing questions. You know, there have been amazing advances have been made in the world of systemic therapy, especially for non-small cell lung cancer. The data that I showed you in the previous slide are for non-small cell lung cancer as well as melanoma. But there is still a fundamental 20% barrier. About 80% of the patients are still experiencing the toxicity of the drug, but not the efficacy. So a question can be asked, can radiation oncology start to bridge this gap, especially with using novel technologies, using novel approaches? And at the risk of being bold and being very provocative, I would ask the question a bit differently. Can radiation therapy be used like a systemic drug? We used to think of radiation treatment as a localized therapy, but can we now think of radiation treatment as a drug and be used as a systemic therapy? So here is an outline of my presentation. I'll give you a brief overview of the current state of technologies, show you some clinical evidence for the development of novel technologies, and talk about some of the novel technologies that have been recently introduced or are on the horizon. I'll talk about MR-Linac, Varian's Halcyon machine, which is promising to introduce real-time adaptive radiotherapy, flash therapy, biology-guided radiotherapy, and then I'll summarize. So what are some of the technologies that are currently available for radiation treatment? If you walk into a modern radiation oncology department, you'll see that there are all kinds of technologies, and this slide just shows you a snapshot. Moving clockwise from the upper left corner, there is the electroperfection unit. It's the gamma knife treatment that we are used to. Accurate CyberKnife machine with multi-leaf collimator capabilities. BrainLab, has recently developed an app, for the treatment of left-sided breast cancer patient, the deep inspiration breath hold. The central panel are all variants, different kinds of machine. So the edge machine, the HyperArc technique, the Halcyon machine. So all these machines have the capabilities to provide real-time or near real-time imaging capabilities to facilitate what is known as image-guided radiation therapy, or IGRT. Accelerators also provide capabilities for gated treatment, for moving tumors. By that, what one means is that if a moving tumor moves outside of the beam, then you turn the radiation beam off, and if they move inside the beam, then you turn the radiation beam off, all done automatically. So this is the principle of gated treatment. You gate the beam. So you see that there has been a tremendous explosion of technologies, and the challenge for us is to really keep up with these technologies. If we don't know how to use these technologies well, then we can actually cause more harm to patients than we can help them. So we are spending these millions and millions of dollars implementing these new technologies in the clinic. The question is, has this advanced radiation therapy improved the prognosis of patients? And the answer is yes. And I will try to illustrate that by taking early stage non-small cell lung cancer as an example. And I'll look at endpoints of tumor control and survival. And I'll compare the outcome data for 3D conformal radiation therapy versus stereotactic body radiotherapy, or SBRT, and also compare the data of surgery versus SBRT. So we know that medically inoperable early stage non-small cell lung cancer patients have compromised cardiovascular function and poor pulmonary reserve, and they also have other comorbidities. So these are the patients who refuse surgery or chemotherapy. When you treat them with external beam radiotherapy like 3D CRT, the 2-year overall survival is dismal, about 30%. And this improved when one introduced the radiofrequency ablation technique, and the survival went up to about 50%. Then came the era of stereotactic body radiotherapy, or SBRT, and the 3-year overall survival from multi-institutional studies is shown to be about 80%, and the 2-year local control is more than 90%. When compared with the gold standard of the surgical data, where for surgery the 5-year overall survival is about 75%. So you see that for selected group of non-small cell lung cancer patients, SBRT is becoming the standard of care. So what are some of the reasons for this improvement in clinical outcome? Again, there are many. I'll just show only on one slide, just highlight just a few. We are able to assess and manage respiratory induced motion. We can better visualize the target. We have better technologies that can deliver a biological equivalent dose greater than 100 gray, while at the same time, they minimize the dose to the surrounding normal tissue. But we also know that a significant number of patients fail. Why? Again, there are many reasons. I've highlighted just a few here. These are tumor bulk, tumor heterogeneity, tumor pace, tumor temperature. And I'm going to spend a couple of minutes talking about each of these. Tumor bulk is the simplest concept. In some cases, there are just too many cancer cells to be overcome by the drug. What is shown here, this plot, a dotted line, shows a growth of cancer cell as a function of time. We have learned that in localized cancer, it requires the application of many cycles of chemotherapy to eliminate the disease, shown by the survival curve in the middle. But the patient may not survive that long. So what we have done for decades is to address this problem is to first reduce the total number of cells using local therapies such as surgery or radiation, which then requires fewer cycles of application of chemotherapy as shown by here. So an intriguing question to ask is that, the debulking of the disease for localized therapy prior to the application of drug therapy, we do that for localized disease. Can we do the same for metastatic disease? Another important mechanism is the heterogeneity between the primary tumor and their metastases. The idea is that the metastatic deposits, they can grow in time with different genetic signatures. And these differences in genetic signature causes resistance to drug. For example, here you can see that this particular metastasis is resistant to drug, whereas that one is not. So this particular MET can actually drive the disease because it's not responding to the drug that's given to the patient, whereas the same drug may be very effective in treating the rest of the disease. So again, one may be able to ask the question, if we are able to ablate this MET beforehand, would that change the outcome of the patient? Tumor pace is an important and an interesting phenomena that we see in immunotherapy trials. In many disease sites, we see an early cliff in the survival curve. This is the survival curve. And what that means is that many of these patients are dying early on, within the first few months, after the start of the immunotherapy. So the prevailing hypothesis is that it takes the immune system some time to ramp up, to be effective after the start of the immunotherapy. So if this disease can be debulked during this early phase in time, when these tumors they progress, then that will buy the patient some time to survive and then potentially enjoy the benefits of the immunotherapy because the immune system now becomes active. And finally, in the context of immunotherapy, we are discovering that some metastases are just cold, which means that they have an environment of cells, cytokines, and surface receptors that are very hostile to the immune system. Even the most active immune system find it very difficult to penetrate these cancer cells and kill these cancer cells. But it just turns out that intervention like radiation can inflame these tumors and convert these cold tumors into hot tumors. So this opens up interesting possibilities, because now when the tumors are hot, they're susceptible to being attacked by the immune system. So it opens up a new world for combining radiotherapy and immunotherapy, so that the patient can now enjoy the benefit of the combined treatment of both immunotherapy and radiotherapy rather than either of them alone. So can complete metastatic ablation or maximum debulking of all the gross disease incorporated into treatment paradigm, will it open a new frontier for the cancer of metastatic patients, for the care of metastatic patients, by addressing these escaping mechanisms that I just highlighted? And are there any clinical evidences to support that? There's actually a good bit of data in the literature that supports the aggressive treatment of oligometastatic disease. This includes surgical metastatectomy, RFA, and SBRT treatments for many tumor types. In fact, the idea of cancer debulking, even in the advanced or the primary stage of the disease, has become the kind of standard of care for many tumor types like ovarian cancer, neuroendocrine tumor, testicular cancer, and glioblastoma multiforme. So what are some of the clinical evidence for this? I'll show you just a few data. I don't have much time to show a lot of data here. So there are some retrospective evidence for complete metastatic ablation. Don't bother to read that. Basically, what I have done here is collected a set of references spanning from 1998 to 2015 for surgical literature of metastatic renal cell cancer. And these investigators have shown that when they do a complete resection of this metastatic disease, those patients have a better outcome compared to patients who go through a partial resection. And in the language of radiation oncology, complete resection is like complete metastatic ablation. And so they have also found that there is a hazard ratio of 2, meaning that these patients who undergo complete resection are twice as likely to live. So that was retrospective evidence, and there are lots of data in the literature. And some data for prospective evidence for complete metastatic ablation with radiation therapy. Here I show data for a multicentric, randomized, controlled phase 2 study for local consolidative therapy versus chemotherapy alone for oligometastatic non-small cell lung cancer. This study is also known as Gomez trial. Patients with stage 4 oligometastatic non-small cell lung cancer are initially treated with induction chemotherapy to stabilize them. Then they are randomized to receive either SBRT or surgery. So what is seen here is that the progression-free survival and the overall survival for those patients who were treated in the SBRT or surgery arm, they're much higher than those patients who are treated, who are not in that SBRT arm. So this is actually significant data, and there are quite a few data in the literature that essentially validates this finding. So that's data for prospective study. Then the next question is, are there any data in the literature that show the synergy between radiation therapy and immunotherapy? There are not many, with the possible exception of this new study. This is called the Pacific RT. It's a clinical trial led by AstraZeneca. And what they did is they treated stage 3 non-small cell lung cancer patients with chemoradiation therapy first, and then they gave these patients an immunodrug durva. What they found was amazing. The tripling, this is the curve with the, when the durva was given to the patients, and that's the placebo arm. So there was a tripling of median progression-free survival. The additional thing that this investigator found from this clinical trial is that if the time interval between the application of chemoradiation and the immunotherapy, if that is short, those patients had better outcome, suggesting a possible synergy between radiation therapy and immunotherapy. So in light of this emerging evidence, we can now ask ourselves questions. And if a patient has multiple meds, do we treat them all at the same time? Do we treat them all? It's the answer is not known yet. Or do we just treat the visible disease sites with IGRT or image-guided surgery, and thereby amplify the local and systemic immunity? And if we want to do that, what are some of the technological advances that actually will allow it to happen? So a question again one can ask, will newer technologies combined with molecular imaging and or immunotherapy change the radiotherapy paradigm and open a new frontier for the treatment of localized as well as metastatic disease? As I mentioned early on at the beginning of my talk, the problem is, these patients with MET are living 1 in 10 chances for surviving beyond the 5 years. The question, again, as a provocative question they asked, can radiation therapy be really used as a systemic therapy? So let me spend some time now to see what are some of the different technologies that are currently available and are on the horizon. So there is MR-Linac that's out in the community now. This is the V-Rays Meridian MR-Linac. It shows the inside of the machine, the split magnet, that can be, it's a modular design that can be pulled out. And the Linac is also modular design broken into different pieces. With this design, both the multi-leaf collimator as well as the source are pretty close to the patient. It's a 0.35 Tesla magnet, 6 MV FFF beam. Elekta also has an MR-Linac that is out that's called Unity. So why does one want to use this MR-guided radiation therapy? There are, maybe the principal reasons are, it's MR-guided setup. It's the visualization, the better visualization of soft tissue structure as well as the target and the organs at risk. And then there are cine MR gating in the sagittal cine plane to really manage the respiratory induced motion. So currently, when you do gated treatment, in most of the centers around the world use CT-based data. So the MR-Linac will actually, this MR-based gating will complement the CT-based gating, and we will now be able to actually get good data where CT-based gating was not as efficient. And then, of course, daily adaptation of treatment plans, depending on the changes in the anatomy. We have been talking about daily adaptation for decades. Now it is a reality. So what I just told you is basically shown in some images. You see superior quality images, and in the middle shown are the daily adaptation. This particular, unfortunately, you probably could not appreciate from distance. So this particular on day 1 treatment, this is not the dose distribution that one expects because of changes in anatomy. And the deviation is shown by this solid curve there. But then when you do daily adaptation, then one gets a better dose distribution. That is exactly how you plan to treat this patient and the DVH becomes the solid line, the dotted line shown there. And then there is, let's see, the gated treatment. The gated treatment there, basically there the idea is, there's a red contour there, and the tumor, when the tumor moves inside the contour, that's when you deliver the treatment, because it's a moving tumor. And when the tumor moves outside of the region that you intended the treatment to be, then the radiation beam turns off. That's the gated treatment. So this slide here, I will give you a very brief description of the workflow for using this MR linac. So you start the conventional way that we treat now. You start with a CT or MR imaging, and you do your target volume delineation and generate a treatment plan from that. Then on the first day of treatment, when the patient comes for treatment, you acquire an MR image, and then, like we currently do, you match the target between the reference geometry and the new geometry, the imaging of the day, and you shift the patient, the table appropriately until there is a matching. Then what one does is moves the target and the organ at risk from reference imaging into the image of the day, perform a deformable image registration to ensure that you have gotten now conformed to the image of the day. One then moves the contours as well as the electron densities from the reference images and moves them into the image of the day and perform a deformable image registration. Then you do a dose calculation using the original plan information. If everything looks right, the data, the coverage of the target looks right, then you do a QA dose calculation and then deliver the treatment. On the other hand, if because of the changes in anatomy, the dose distribution on the target is very bad, then you do a re-optimization and you redo the dose calculation, and until an acceptable plan is obtained, and then you do an independent QA calculation using a Monte Carlo algorithm. When all of those are done, and then you deliver treatment. And all of those are done with the patient on the table. And here you see an example of doing this. On the left is data treatment for a pancreatic tumor. Here's the target, and in a prescription dose you can see nicely covers the target. Here's the liver, duodenum there, and stomach there. Then you go to the next day of treatment, and you see how the liver has changed in size as well as the duodenum and the stomach. And this changes in the daily anatomy causes a total change in the coverage of the target. So unless you do by looking into that and you do a real-time changes in dose calculation, you will not be covering the target as you wanted to, and you may end up giving a lot more dose to the organs at risk, thereby increasing the toxicity. So here, real-time adaptation was done, and then you see what the data looks like there with a good coverage. This slide shows some recent data published using this MRI linac for pancreatic tumor, a deadly disease. Data from 5 centers and 44 patients with inoperable pancreatic cancer treated with this MR linac. The patients were split into 2 groups, a high dose group with a biological equivalent dose greater than 70 gray, and the standard group less than or equal to 70 gray. The high dose rate group showed an overall survival at 2 years, about 49% compared to 30% for the low dose group. And that's a significant accomplishment for this deadly disease. And the median overall survival was twice as higher for the high dose group, 20.8 months versus 10.8 months. The other important thing that they found was because of this daily adaptation, no patients in the high dose group experienced grade 3 or higher toxicity. So with this daily adaptation, they were not only able to deliver a much higher dose to the target, but they were also were able to reduce, eliminate serious toxicity. This is data that just got published in Red Journal, for 101 prostate patients treated with SBRT using this MR-Linac. Obviously this is too early to talk about survival, but what they found is that the toxicity for the treatment with this daily adaptation is much lower compared to when these patients, similar patients were treated using the conventional SBRT. This slide shows what Varian is going to do. At the last Astro Day, announced that they will be using artificial intelligence to do real-time adaptation. What will happen is you'll acquire a cone beam CT on the day of the treatment, and using artificial intelligence, you'll have the contours drawn on the target. There will be an adaptation you'll do if necessary if the contours do not look right. There will be dose calculation, adaptation of dose, approval of the plan, and QA calculation and treatment delivery. All real time with the patient laying on the table in 15 minutes time window. So they are promising that. We'll have to see what the outcome is. So let me switch gear and talk about a new type of treatment that is buzzing all around. This is known as flash therapy. So what is flash therapy? It is radiotherapy where high doses are delivered at ultra-high dose rates in hypofractionated form. I assume there are many clinical medical physicists in this audience here, and when you use a linear accelerator in your clinic, you are probably using a dose rate of 400 centigrade per minute, when you treat your patients. So I'm trying to give you a perspective what flash therapy is in terms of ultra-high dose rate. So then there are new machines that have come up into the community. Varian has its true beam with the flattening filter-free beam. Electa Versa has the similar machines, similar beams. And this, for a Varian 10 MV true beam, the dose rate is 2400 centigrade per minute. Varian also has a proton machine with a dose rate of 10,000 centigrade per minute. And guess what? For flash therapy, get ready. It is a whopping 720,000 centigrade per minute. Imagine, to reiterate, it's 720,000 centigrade per minute. Imagine turning this machine on and off. Less than a fraction of a second. This beam will be turned on and off, the patient will be treated. Imagine all the quality control and immobilization stuff that we medical physicists will have to worry about. So the preclinical data have shown that this flash therapy is actually effective in the range from 40 gray per second to about 120 gray per second. So I'm going to show you some preclinical data using this flash therapy using both electron as well as protons. So this is a set of data that was first published by a group called Favudan et al. What they did is they took the normal lung tissue of mice, that's shown here on the left, and then they took another lung tissue of mice and treated them to a dose of 17 at a conventional dose rate of 0.03 gray per second. They also took this lung tissue and treated them to the same total dose of 17 gray, but at a much higher dose rate of 60 gray per second. As you can see, so there's a significant fibrosis when you are treating at a conventional dose rate, but there seems to be none when you are treating at a much higher dose rate. So these authors conclude flash spares normal tissue. Here is another set of study, looking at the skin toxicity from irradiation of mini pig, 36 weeks post-radiation treatment. Conventional dose rate is 5 gray per minute, and the flash dose rate of 300 gray per second. Upper left corner, you see there's the 3 areas treated. This is the conventional treatment, 34 gray, 31 gray, and 28 gray. And you see significant skin toxicity when treated in the conventional fractionation dose rate of 5 gray per minute. On the other hand, if you treat with a flash dose rate of 300 gray per second, you seem to see no such skin toxicity. And these, on the right here, shows the dermal layer breakdown when these pig skin were treated with flash dose rate versus the conventional dose rate. That's the control, unirradiated. Here you see treated to a total dose of 34 gray in the conventional dose rate, significant dermal layer breakdown, and that's the data for when treated with flash therapy to the same total dose, which seemed to show none or little dermal layer breakdown. So flash spares the skin from toxicity. This table here shows data for whole brain flash irradiation for mice treated for the flash therapy greater than 100 gray per second. So the endpoints for this study are looking at macroscopic toxicity, the cognitive skills, 2 months post-irradiation, and cellular toxicity. So when treated with the flash therapy to a total dose of 50 gray, there were no toxicity seen, there were no changes in cognitive skills, there were minor cell killing and better survival of the neural stem cells. On the other hand, when these mice were treated with the conventional treatment, the maximum tolerated dose reached was 10 gray. There were drop in cognitive skills, and there were high level of cell killing, as well as and complete eradication of the neural stem cells. This slide here shows data for total body irradiation, and the data is for both dose rate and total dose. On the left shown are the data, the survival data when these mice were radiated with a dose rate ranging from 0.04 gray per second to 50 gray per second. And as you can see, this blue curve there are 100% mice survived when treated at 50 gray per second dose rate. But on the other hand, when they're treated to 2 gray per second, beyond about 7 days, there was no survival. On the right is shown that when you treat with a flash dose rate but different total dose, when treated to a total dose of 16 gray, the survival was the maximum, and flash 20 gray was found to be comparable to conventional 10 gray dose. Similar result was seen for other strains, and flash was always found to be superior to conventional treatment. This slide here shows a dose escalation studies in cats with squamous cell carcinoma of the nasal plunum. The dose rate that was escalated was from 25 gray to 41 gray. 14-month post flash irradiation, 5 of the cats were still alive and was doing well at the time of when they reported this data. So this slide kind of summarizes some of the data that I mentioned for both normal tissue and some tumor tissue. I didn't have time to show you data for tumor, impact of flash on tumor control. But basically for brain, lung, GI, and skin toxicity with a flash dose ranging from 10 to 30 gray and conventional dose 10 to 20 gray, the findings are flash increases normal tissue sparing compared to conventional dose rates, and there is better tissue sparing with increasing dose rate. For the tumor of breast, head and neck, GBM, and squamous cell, the tumor control was the same or better with flash therapy compared to conventional dose rate. So those are the data that I've shown you for electrons, and there are some preclinical data that are used, that are available, done by protons. And here is some data. This is a 7-arm clinical trial study where about 400 mice were entered into this study. So there are 2 sets of experiments done. In one group of study, you have the control, where the mice were not radiated, and the other sets of mice were radiated with both conventional dose rate as well as flash dose rate to a total dose of 15 gray. And in a second study, the total dose was increased from 15 to 17 and a half, again radiated with both flash and conventional treatment. The endpoints were survival, dermatitis, and fibrosis at time points ranging from 24-hour, 8, 16, 24, and 36 weeks post-radiation. What the findings of this study was, flash therapy resulted in a 25% reduction in the fibrosis compared to conventional treatment of 17.5 gray, and a 35% reduction in the dermatitis. Here you see some stained samples of tissue taken from a tumor inside a tumor tissue and irradiated again with conventional versus flash radiation. In the lower panel, this is an M-cherry staining. You see all these dots are live tumor cells. So the control arm, you see lots of live tumor cells, but when they're radiated with flash therapy, you see lot fewer live tumor cells compared to when they're treated with conventional fractionation dose rate. The upper panel shows that the destruction of the cellular structure is much more using flash therapy compared to conventional therapy. So to summarize the advantages of the flash therapy, it's a radiation therapy is a non-fibrosing radiotherapy compared to conventional radiation therapy. And flash RT shows a dose modifying factor that is at least 20% for single fraction treatment in favor of flash for the protection of normal tissue and prevention of fibrosis developments. It's a novel modality of irradiation. It markedly increases the differential effect between tumors and normal tissue and is able to destroy tumors while better protecting normal tissue and preventing side effects in the experimental models. So given the radiobiological and the delivery advantages, flash radiation therapy actually could be the future, could really revolutionize the field of radiation therapy. The next technology I'm going to talk about uses information obtained from molecular imaging for treatment planning and delivery. Here I have listed different PET tracers that can be used to identify different molecular processes. We all use FDG. We know this is characteristic of glucose metabolism, which is a sign of increased metabolic activities. And then there is F-MISO, and it shows increased hypoxia, FLT for DNA synthesis, and it indicates proliferation. And then there are many other tracers. Each of these tracers, indicates some activity for different kinds of tumors. So two smart guys asked this question: can we use this biological information obtained from these tracers and use it as a biological fiduciary to do image-guided planning and delivery of radiation treatment? And if we can do that, that will be phenomenal because, for example, here you see the uptake in prostate for the tracer PSMA. So if you are able to identify where the disease is, now you're able to deliver radiation dose to the active area where you minimize dose to the surrounding normal prostate tissue. What if we could use tracers like FET for the treatment of brain tumors, or use hypoxia for selective boosting for head and neck tumors? Then there are GS68 deuterated the tracers, and this tracer is used for both imaging, for advanced endonuclear tumors. Patient is injected with this tracer, and this tracer is taken up by somatostatin receptors in the body. So the endonuclear tumors have a lot of these receptors, and they take it up. So GA68 deuteratate is a positron emitter. You can do a PET CT imaging from this, and that tells you precisely where the target is. For treatment, radiation treatment, there is a new drug, a new targeted treatment, which is known as lutetium-177, that is given to these patients, and that is taken up by these advanced endonuclear tumors. But the problem with that drug is that it goes into bladder and into your kidney. So now, if you have, say for example, a situation when there are multiple tumors in the same organ or different organs, and these are all the, say, the mets that are there, currently the way we manage them, we will treat them probably one met at a day and treat them on different days. Are there technologies out there that will allow you to treat all of these on the same setting? Okay, and yet minimize those to surrounding tissues. And this is the concept being you use the PET tracers, for example, and if you can tell the uptake of all of those, and the idea, the goal is to be able to treat all of them at the same time. And that's the new technology that's on the horizon. This here shows the principle of how one can use PET in a real-time way and use it as a biological fiduciary. The concept is simple. You inject the patient with, say, FDG, and it's taken up by the tumor, and we know that there will be two photons that will be coming out in opposite direction. And once you know which way these photons are coming, then you can calculate precisely where that tumor is along the line of travel of these two photons. I don't know whether you can see it. What is shown here are a bunch of PET detectors, and here is the tumor, and there is a straight line along which these two photons come in opposite direction. They're detected. And then what you do is, the tumor is along those lines, and you bring a radiation, beamlet of radiation, and fire those radiation along those lines, because you know precisely what the target is. So it's as simple as that conceptually. And if you can do it fast enough, then you really address the problem of the motion management. And and then you wouldn't have to worry about all this anatomic imaging that we do currently. In a way, you are using this biological information as a fiducial to target where the tumor is and treat the tumor. So here is a video of what this technology looks like. So this is sort of what this technology looks like. This technology has a 16-slice CT scanner. A little slow for this, the movie. It has a 6 MV linear accelerator and 2 banks of PET detectors. Okay, there is also MV detectors there. The system, the linear accelerator, has to respond to all those emissions that come from the FDG, say for example, the tracer. So it has a multi-leaf collimator that has to open and shut very quickly so that it can respond to all the emissions. So the patient is injected with a tracer, PET tracer. In this case, say this patient has tumors in 3 different organs and 5 different tumors. And you have to treat all of them in one setting. So the workflow is still to be determined, but as the way the vendors are thinking is that you'll still start with the patient laying on the table, and then you have the reference image from the planning CT, and you do match the planning CT with the image of the day, and you shift the table to match the target of the day with how the reference CT was done. So you move the table. So once you have done that, then you see, I hope you can see it, there are, these photons will be coming in all 3 dimensions. So here's the tumor, and there will be the photons coming in every dimension, and they're detected by this PET detector. So after they're detected, you bring the multi-leaf collimator and fire radiation along the line that you see these photon beams are coming in opposite direction. So with this now, you have a capability to treat multiple mets on the same setting. So it actually opens up a world of opportunities because there's a lot of unknown. We don't know whether we want to treat, if a patient has multiple mets, 5 mets in 3 different organs, we don't know, do we want to treat all of them? If we treat 2 of them, if we treat a certain volume, what impact of one will have on the other in terms of the radiation really priming the immune system and have an impact on some of the other tumors. So I started my presentation by showing this slide. One of the things I said that, we have learned how to deal with the localized disease, and one of our main problems were all the different metastatic and the patients with the different mets. And the question that I asked, are there different technologies that is now in our hand which will be able to bridge this gap? So hopefully I've given you some information where the future is really, there's a lot of opportunities. Some of these technologies allow us to really understand how we really treat these patients. So to summarize, disruptive neurotechnologies might facilitate radiation therapy to become an effective drug that can be used as a therapeutic agent for both local therapy as well as systemic therapy. Technologies such as MR-guided LINAC, halcyon, with adaptive radiotherapy, reflection and flash RT could actually revolutionize the field of radiation therapy. So here are some of my acknowledgements. So the future of radiation oncology, flash therapy, technology, cancer biology, it's really a combination of all of them, technological innovation, molecular imaging, immunotherapy, flash therapy. Scratch sheets. Thank you very much.